Interesting that appliance efficacy is increasing while the rate of obesity is also increasing rapidly. Please comment.
Oh, that's a very good question, actually. And unfortunately, I don't have the answer to that. We do know the obesity is increasing, which does increase the rate of sleep apnea. We do know that for sure. And the BMI does impact the efficacy of oral appliances theoretically, actually not theoretically, with evidence in a negative correlation. So the question is, how is these appliances getting better with time? And to be very honest, as I said, we don't know yet today. We do have some hypotheses, we do have some ideas, and we think that maybe it has to do with better device manufacturing, better follow-ups, better testing, better technologies, and all that. But the exact reason for it, it's yet to be discovered. So I think there is a lot of research that needs to be done in that area to understand which devices are used for what phenotypes, perhaps, or even what endotype of the patients as well. I think it goes beyond that, saying that there is one size that fits all, right? We got to look at what is available. We got to look at the patient. So I think we're going to learn a lot about those as we kind of look at more personalized research in terms of what can help us in device selection, for a lack of better term.
Thank you. Now, a second part from the same member. A second thought about patients who don't respond to oral appliance therapy. What do you think are some of the issues we're not yet detecting or understanding? We may not be able to figure this out until we do DICE procedures on them.
Yeah, that's a great question. Of course, we do know that when we look at patients with a sleep apnea, there is many factors. Some of them happens to be anatomical, which has to do with their airway size and collapsibility. But there is a lot of other factors, physiological factors, such as their critical pressure, such as their loop gain, such as their lung volume, and so many other factors that could impact their sleep apnea as well and their response, right? What we do know, for instance, patients with higher loop gain, they don't tend to respond as well to oral appliances, where patients with lower loop gain, they tend to respond better. We don't understand the real reason and real physiology behind it, but those are the things that we're learning more and more. And of course, DICE, I know they mentioned DICE, we do a lot of that in Antwerp, helps us with understanding the anatomical constriction and the anatomical problems of the patients while they're going through drug-induced sedation. I had a colleague of mine that called drug-induced, instead of sleep endoscopy, was drug-induced sedation endoscopy, which is correct. We can look at that, and we do understand that, for instance, concentric collapse patterns don't tend to respond well to oral appliances. But why? We don't know yet. And you've done a great job, right? Your answer is we got to learn a lot more. I think we're just getting to a point that we're realizing the things that we don't know. You don't know what you don't know until you get there. And I think that's where we're kind of getting there.
Thank you. Could you explain more about loop gain, please?
Yeah, loop gain, I'm going to try to simplify that. It's basically the stability of your ventilatory control system, which is basically kind of measures how well your ventilatory center responds to these respiratory stresses that you're getting, the lack of oxygen, the AHI. And the higher the loop gain, that means that you got a more exaggerated response to this stimuli. So simply putting it, it's just, I was going to explain it simply. You can look at a heating system in a house, right? You got the furnace, you got the thermostat, and you got the room temperature. If you set up the room temperature at 21, a system with good loop gain is going to detect any variation in that temperature, half a degree, and right away send a signal to the furnace, and the furnace is going to send the right amount of heat, and the temperature will be maintained in that 21, maybe 21 and a half and 20 and a half degrees. That's a stable system with a basically stable loop gain. A system with high loop gain will be a system that you'll see that it will take a long time for the thermometer, for the thermostat to detect that drop in temperature. And when the signal is sent to the actual furnace, a lot of heat is being sent out. So you get this huge variation of temperature. You perhaps, as an example, 18 to 23 degrees, that you get those fluctuations. The same thing applies to our breathing, right? If your body responds exaggerated to that breathing stimuli, then you have a high loop gain system, which don't tend to respond well to oral appliance therapy. I hope that kind of makes sense a little bit. I can go over the technical part of it in terms of the plant gain and everything like that, but that's what basically it is. How stable is your ventilatory control system?
Good, thank you.
I want to tell you, this has been a journey of mine as Dave sort of dragged me down this rabbit hole
Come on now.
of sleep medicine. You can't get away from this. All right. And why I'm commenting is that we as a country our health system is in terrible distress, where premiers are scavenging healthcare workers from other provinces and on and on and on, trying to get enough personnel to keep a health system which is draining the coffers of this country. And on one hand, sleep medicine or sleep apnea and that kind of thing is part of the problem. But that's not really what I'm going to be talking about. I think you are a scary guy for the regulators in this country, because I believe that there's a general move afoot for the regulators, and especially in Ontario, that are regrouping, retrenching, and changing the pattern of allowing dentists to reach out besides the dental alveolar complex. And temporal mandibular joint pain and sleep is a way out on the periphery.
Mm-hmm.
I believe the question is more than just thinking about how we can improve our performance in our therapy for sleep apnea patients, to taking on the battle of understanding that quietly and significantly, they are in the process of probably shutting down sleep medicine dentistry. Mm-hmm. That is a scary reality. And so this rabbit hole that I've fallen into and understood and appreciated what we can do for people, I believe is problematic unless we begin to understand that there's going to be a war take place. And the regulators are going to say, well, if I can't relate to what you do with periodontal disease and restorative dentistry and all of that good new stuff, which is easy to calibrate, easy to control, a system where provincial colleges have lost control because they're opening up that thing, that we have a real problem on our hands if we're going to do sleep medicine. Now, this may be really crazy, but I'm just throwing this out to you that it's really, really going underground by the regulators. I mean, before we knew them as colleges, now they're regulators. Mm-hmm. And you know, all of that skill and talent that you have and the hard work that you've done, unless we grab hold of this and understand this, that there's really two battles to be fought, that sleep medicine isn't going to be in the game.
Mm-hmm. Yeah.
Sorry, Laura, are you saying that the RCDSO is interested in shutting down dental sleep medicine?
I believe that it isn't. They're not going to say to you, "We're going to shut down sleep medicine dentistry." What they're going to do is they're going to say, "We don't understand. We don't understand what you're doing, and if we don't understand what you're doing, and if we can't relate it to a dental alveolar complex, then we're going to say to you, you're out on the edge." We've been always on the edge, but now they're going to pull it back. That's what I'm saying.
Have
And
you
I-
heard them say anything like that, or have you heard anything
The
like
movement
that come
is,
from an official source?
they don't say that stuff. But you've got to look behind the scenes, the change in their wording of what they're responsible for has now been more isolated to the dental alveolar complex. They're changing the territorial perimeters of what they're going to regulate. And that's what my fear is, because we've come a long, long way in helping patients. And I'm afraid that if we do not begin to start sniffing around and understanding what's going to happen, I think they're going to blow the doors off of this.
Laurie, with all due respect, maybe we'll give John a chance to counter that, because he's very close to it in Toronto. So John,
So, sorry. Hi, Shouresh. Great, really.
Hi, John. Great
Always
seeing
enjoy
you.
listening to you. So what you need to know, Laurie, is that there's a group of us that are preparing a letter to reach out to the RCDSO, and we're like probably less than 14 days away from sending it to them. So that's not really even public information yet. So for those of you on the call, just know that, you know, something is going to be happening very shortly. And it is an effort to try and get them to get on board to actually establish guidelines for Ontario, like they have in Nova Scotia, like they have in Alberta, like they have in British Columbia, like they have in Quebec. So like we're way behind here in Ontario. And they're getting a very heavily cited letter from our group. And it's, you know, all the evidence is there. Dental sleep medicine is absolutely only going one way, Laurie, and it's going to become a thing that is more official in Ontario. I don't believe it's going away whatsoever. You know, they regulate everything we do. We can only work under their direction, under their license, as per their guidance, that they control what we can do as a dentist. That's always been the case. And the thing is, they need to have a better understanding of dental sleep medicine, which we can help them get. They just have to understand. And we had the previous guard with, you know, Irvin Pfeffergard and Michael Gardner on board. They had struck a committee, and they were in the midst of picking people to be on that committee, and then COVID hit. So it was put on the back burner. And so like we had made a lot of progress over a few years of working them. But now with the new guard in place, it's like starting from scratch, because these people just came in, wiped the chalkboard clean, and okay, we got our agenda, what we're going to work, you know, and dental sleep medicine wasn't even on their radar whatsoever. So
Right.
over this last year, a number of emails have gone out to them, and now we're at the point where we're preparing an official letter to go out to them to pursue this initiative, right? So, you know, things are happening, but behind the scenes right now. And we're way behind in Ontario compared to these other 4 provinces, but we'll catch up.
folks, you have no idea how lucky we are to have a speaker tonight who not only lives outside of Ontario, which I have often called the black hole of healthcare. He lives in Alberta, and he can, Shouresh, I'd like you to speak for a few minutes about your reaction to Laurie's comments living in Alberta. But more importantly, you have traveled and educated and taught all over the world. Globally, where do we sit? Are we really that far behind? And what do you see as the future?
Yeah, that's all I'm gonna say is I hope we don't go in that direction. You know,
Right.
It is always a concern, right? You trying to expand what you can do as a profession, and the regulators, as we hear sometimes, they might have some restrictive. But the way I look at it is, dentists have and must have a place on the table when it comes to not dental sleep medicine, when it comes to sleep medicine. We have a therapy that, in my opinion, needs to be provided by very well-trained clinicians, dentists that have the training in this area. And it would be a shame, it would be a pity if we see the opposite happening. And what I can say is, in Alberta, we've been lucky. We've seen a different move. We have a guideline that came out in 2019. which was a good move. It was in the right direction. Some of you folks have read it already, and I feel like it was a step in the right direction for what we're trying to accomplish. It really promoted that collaborative model between the physicians and the dentists and all the people that are involved in the field. And what I'm seeing globally, Dave, you asked about that, it seems to be the same. It's that collaborative model between the different parties that are involved in sleep medicine. Happens to be whether it's a respirologist, pulmonologist, a ENT that is a sleep specialist, with the sleep centers, with the sleep lab, with the dentist, and all the different parties that are involved need to work collaboratively together. That is always the best model, depending on which country you are, especially when you look at in Europe. It is so diverse. It is so diverse. For instance, when you look at Netherlands, as I said, you see 50% of patients getting oral appliances. And is that because they have a better medical system? No, it's just their insurance model that always comes up in the conversation, right? Doesn't differentiate between the two and looks at them equally. Same in Sweden. You look at Belgium, for instance, as of today, only 2% of patients are going on oral appliance therapy. So it's even worse than North America. Of course, that's about to change, hopefully in the next few years. But overall, I can comment, I can relate to the fact that, you know, we hear that a lot, that maybe our health system is broken. Maybe it is. Maybe it is not. I don't know. I'm not a politician to make a comment on that. But what I do know is sometimes it takes a while for the guidelines and for the standards to catch up to science. And sometimes it takes a while even for the protocols to catch up to what's available to us, right? Even when we look at what we can do in dental sleep medicine with digital workflow, perhaps I would say less than 10% of people that are doing dental sleep medicine are utilizing what's best available to them. And I think we got to focus on providing quality care. And that in turn, hopefully, will not allow regulators to come in and shut us down. You got to have a good way to defend yourself and defend your position. I don't know if that answered the question, but I would be very concerned and I would be very sad if we went backwards. I'm hoping that we move forward from here.
Right. No, that's very good. Thank you for that. And I do have one more written question, and I will present that. It may seem a bit unrelated to your topic, but it does strike at what a lot of us in chronic pain deal with. So this is a supposition. Let's say you made a mandibular advancement device and the patient's very happy. A couple of years later, the patient starts to experience sympathetic dystrophy. And we all know what that means. What might have happened? That's you only got 7 hours to fix that one for it. So very quickly, do you have a response to it? I know it's an open-ended question, but
lots. Simple responses, lots. But I think it raises a good point that I like to always focus on, and that's realizing that dental sleep medicine, oral appliance therapy is not a one-time treatment. It's not a one-time therapy. We're really focusing on long-term management. We're not treating anybody. We're managing their disease, and whatever we decide to do, like we talked about treatment selection, we talked about patient selection. I think that's one of the criteria that needs to be looked at very, very closely always, that the treatment that is being recommended, is that a treatment that is going to last this patient a reasonable amount of time, 2 years, 5 years, 10 years, whatever you choose that's going to be for the patient. But we're dealing with long-term management of a chronic disease. And like any other chronic disease, any type of a lifestyle changes, any kind of a medical changes, any kind of environmental changes, psychological changes, those are all the factors that would play a role in managing these patients. So we got to keep an eye on those. And that's why proper training is extremely, extremely important.
excellent. Yeah.
Just like we are accountable to the RCDSO, right? Because they govern our license and our ability to, our right to be able to practice dentistry. They are accountable to a governmental agency, and their mandate is to protect the public, right? So, I mean, they have a responsibility themselves. And
Right.
the approach we're taking with the letter, it really sort of like it's hitting a lot of sensitive buttons with regards to their responsibility and the fact that these guidelines or the absence of actual guidelines is a problem, you know, and them fulfilling that responsibility. So I really, Lori, honestly, I really believe wholeheartedly that this is going to go in the right direction. The only thing that I don't know is how long it's going to take. As Shouresh will tell you, the process in Alberta took, you know, much longer. Hopefully, the fact that we have 4 provinces that have already done it and put it in place, it'll help us to fast track it, you know, because the groundwork has already been done in those 4 provinces. So I'm hoping that that will help us to get through the process more quickly in Ontario.
John, is it, John, are you going to release this letter once it's submitted to the RCDSO?
Well, and once it's released to the RCDSO, it will be public information, of course. Yes.
I mean, they'll publish it themselves?
Well, no, I can share it then. You know what I
Well,
mean? So
okay, well, that's my question. Once it's safely there, I'd be happy to put it on our website.
absolutely.
Yeah, no, not all our members are.
It's just that it's still in draft form and it's not
I know.
final. So that's why.
Yeah, well, once it's submitted, I'd love for our members to have access to it. Laurie, I saw you raise your hand again.
I want to thank both John and Shouresh for their responses, and I'm just concerned that we go blindly down the road, down the rabbit hole, thinking we're going to be committed, conscientious, and competent practitioners, and we get sandbagged. And that's all I'm saying. And I just really think that I wish you and your group, John, of being successful. That's foremost in my mind. I'm just was raising the call to be a little conscious that there is a movement other than what you're thinking clinically is happening in the world of regulators. And of course, the politics of regulators are influenced heavily by governments, and we no longer are self-representing at the college level, and it's going to change dramatically in Ontario. And it started out west when they brought in Clayton in the BC government, and it's going across the country, and they're revamping everything.
The thing to keep in mind is that we have very, very, very good evidence-based guidelines in place by the AADSM, and the RCDSO we know respects the AADSM. So, you know, what we need them is to just make specific decisions about how things should be handled here in Ontario, right?
Okay.
Fill in the blanks.
Well, you've been a leader for a long time, so we wish you all the best, and I'd be happy to share that letter once it's public. Thanks so much for that.
To be what we must do, if we're going to tread into these areas.
Yeah, absolutely.
My pleasure, and thank you for having me on board, and thank you for everybody that was with us, of course. Thank you, David. It's always a pleasure.